This is a right knee, and so you can see on the lateral side we mark the fibular head just so you guys can see the orientation. This is a little different portal setup than you would do normally arthroscopically. Again, for a lateral side, you're going to need a little different portal setup than you would with the medial femoral condyle, in which you would just use 2 portals. So you can see here, this is a standard lateral portal here, and I'm going to go in and show you. So this is the standard lateral view that you would see for your initial diagnostic arthroscopy evaluation. We've also removed some of the fat pad that's incredibly important in arthroscopic procedure. And you can see that we can see all the way around this. So this is the medial femoral condyle. We are not going to do a MACI Arthro on this side. We're going to do it on the lateral femoral condyle. So once you've made this, you have your working portal medial. You're going to switch to your medial portal to view laterally, arthroscopically. So you can see there. So we've now pre-made this. So you can see from the shaver, this is in the working portal laterally. So you can clean the defect. Again, you can see that this cadaver had a defect of the lateral femoral condyle, which we are going to do a MACI Arthro on. Okay, so you're going to be able to clean it from this side. And then using the sizing guide and the guides for the cannula, we decided to use a smaller cannula. This is a 15 by 3 millimeter in depth, and they go up to 4 millimeter in depth if you have a deeper knee. And so the cannula is already placed. This is a transpatellar portal, and we've enlarged it so that the cannula can get in. You can see the nice black markings here. And you really want to make sure that you go in angle or in line with the defect. You want to see your guide. So we use a spinal needle. There you go. You see how we're completely in line with the defect. We're not off to the side here. You can see if we went through the standard lateral portal, you see how you'd be completely off. And that's a bigger challenge when you do a lateral side. So you want to use this portal where you have good placement. Again, portal placement is key for arthroscopic procedures, and especially when we're doing something such as the MACI Arthro. Again, so now we've got our good portal placement, and we have our cannula placed. Now we're going to measure our defect size to prepare for cutting. So this is the new MACI Arthro measurement guide, and this will fit through the cannula. And then what you can do is you can deploy it and measure the length. Now you can see here the thicker black line is 10 millimeters in depth. So you can see the length of your defect. So we're going from superior to inferior. And then you can also rotate it around. Rotate the camera so you get a good view. And you can see as well, so you can measure your defect size. So in this case, we're going to go with one of the smaller cutters. And this will give our template. It will use as a template to guide us in terms of what size we want to go, similar to what you've seen in some of the open instrumentation. And again, you can see it's angled so it goes smoothly through the cannula. And again, I always use a gentle bit of rotation to get it in. And then you'll see you'll let the fluid fill back up. And then you're in the intercondylar notch. If you do this outside the intercondylar notch, you will likely damage the cartilage. So the key is to stay in the intercondylar notch. And then what you're going to do is push up to deploy the cutting guide. And then you can have your assistant either flex or extend the knee. Good. And now we've got it aligned well, right about where we want it. All right, if you don't mind malleting for me, please. And you can watch it get seated. And you can see there's certain areas where it's higher or lower. You want to get all the way down right at the subchondral bone. That's perfect. Maybe a little bit more, please. Excellent. So we're going to come off. You can see we have a really nice template there. So now we're going to, again, key is not to pull out like this. You have to completely flatten it out. So doing the opposite of what we did before. Good. Pull back. And then again, the key here is gently rotate. You will pull your cannula out. Now again, I have an excellent assistant, but you're gently pulling this out so that you don't pull the cannula out as well. So there's 3 types of different curette options. The first one is this circle. This is going to be my workhorse. Thank you. And then a little resistance, especially in this case, as we prepare the defect. Now again, we want to go to the calcified cartilage layer. Nothing past that. And again, we're going to use that cutout as our template. And that helps us with how deep and how far to go. Superior, inferior, medial, and lateral. And again, as you're doing this, You can take the cannula out if it's easier. And that will be, especially in larger defects. We have a perfect location here for the defects, so we're able to do most of it without having the cannula removed. And then going back and forth to just go between that and the shaver, just to clean out any of the loose fragments, because it will hurt your visualization. And just take your time. Again, the nice thing here is you're not making any open incisions, and it will save time as well with closure. What excites me about this procedure is really the technological advancements with the actual tools themselves. The cutting guides allow you to set the entire procedure up from the arthroscopic standpoint, and the ability for the guides to retract, come out of the cannula safely, and go back in and really make that nice cut on the condyle and outline is quite impressive. And again, we're doing a lot of this with the single device. And again, you will get your feel on how you do it. Everybody has smaller techniques, but again, the key here is just to do a really good job of guiding that outline. So you can see this is the square guide. This is really nice for sharp edges. Also good for some finishing touches as well. And the rake is really nice for getting those really sharp edges. And you'll also see what I'm doing is I'm really getting my fingers as close to the cannula as possible, using it as a guide. That prevents me from slipping and doing any damage outside of the defect. It gives me a lot more control. Sometimes, if you're able to get if you have a good position, you can actually have someone hold the camera for you as well. In this case, we don't need to do that, but someone holding the camera and you really are just, if it's really tough cartilage in some of these patients, again, it varies in terms of the quality of cartilage you're dealing with. Holding the camera and just using two hands to be really careful is important. But again, you can move efficiently with these devices. Could I have the rake, please? Thank you. And again, you can also see that I can come from other angles. Now I've got 3 portals to work with. Good. And then we're going to switch to the other portal if we want a better angle. And you can see how nicely we get those borders. So again, it's really important, and it's nice in the set that you have 3 options. So really just keep working an option that's working for you and then try the other option. Again, this square one I really like. It's double-sided. So you can really cut that defect down nicely. And again, once you get the border going, it's a lot easier, but the key is to get that border. Would you mind extending a little bit? Great. So here I'm guiding my assistant. That's really important when you do this. And again, in this case, you'll have the fluids a little bit higher, so you'll have less extravasation as well. And you can see one trick I'm doing. You see how if I take my hand off, we lose fluid through the cannula. Again, you want to make sure the cannula is big enough so you can get all these instruments through it. But if you start to lose a little bit of fluid, you can go up on the fluids, or you can try to kind of seal it off with your fingers. And you're there already because you're guiding the curettes down without moving any damage. In my hands, I feel like all patients with lateral mediofemoral condyle defects now with size 2 to 4 square centimeters are excellent candidates for this procedure. The major benefits to the patient, there is the ability to have smaller incisions. We no longer need arthrotomies, especially for these medial and lateral femoral condyle defects. It allows patients to rehab faster and with less pain with a smaller incision. And to have this such a technically unique instrumentation allows for reproducibility of the surgery, so we can continually do the same high-quality MACI arthroscopically. So you can see here, we're really trying to get that nice defined border. What you'll find is the upper and the lower borders are the most challenging, so be patient with those. The center, coming down the sides of the condyle, those tend to be a little bit easier just because of your angle of attack. So again, try flexing a little bit, see if that helps. Oh yeah, that's much better, thank you. Good. So I'm going to go back into my main viewing portal for the lateral femoral condyle, which will be on the medial side. Good. And then can I have a shaver, please? Thank you. And again, here we're just cleaning up any loose fragments that'll get in your way of the scope. Can I have the template cutter? Thank you. And again, remember, inserting it in without being deployed, rotating slowly into the intercondylar notch, then deploying it, and then trying your best to lay it down. And again, You can see that if you rotate it, so see how there's the hinge on one side? So there's a little bit of an angle of it, so I'm going to use that angle to my advantage. One of the tricks you can do, you see I'm just doing a light bit of rotation on it. Again, you don't want to over torque this device, but if you just do a tiny bit of rotation on it, so mount that again, you can see you'll seat it really nicely. Good. And then you can come off, and you see we're really, really close to being ready. All right. So we'll go back into the full deployment of it. Good. And then we're going to slowly rotate it out. Excellent. Good. Let me have this square. There's also a little bit of a tactile feedback to this when you do it. As you take down the cartilage, you feel it go from hard to smooth. So you'll get used to that as you do more of these. If you're ready to do MACI open, then that tactile feedback is very, very similar. And you can see if you've done a good job of those borders, let the instruments work for you. Get that edge caught, and you just slide it down carefully. And then as I fall off, it's hard to see directly on here, but as I start to slide down, I pull my hand back just very gently, basically just lay off the pressure. And then we can kind of use it as an angle here. That's looking pretty good. Don't be afraid to have an extra portal. It's not going to do anything in terms of your overall speed of the procedure, recovery, etc. You really want to maximize, again, arthroscopic approaches to these type of things. An extra portal here or there for retraction, tool usage, and to get the right angle is key. So especially with the lateral side, which can be a little bit more difficult. So what I'm doing is just kind of raising it up, but I don't want to dive too deep. So if I just kind of turn my hand a little bit, and I'm counter pulling, I'm not diving in with the cartilage, I'm just using this as a scraper. And as you get more comfortable, this will be faster in terms of preparation. And I'll show the rake one more time. You can go back to just regular, thank you. Look at that small piece of tissue that's in our way. I'll just show you guys the rake one more time in terms of how you can get really nice edges with it. You can see you can just sort of guide it up there, which is really nice. We've done pretty well on this. I think I'm happy with it. I'm going to put the cutting guide one more time in, just for our final check. Again, really important. All right. And we're going to rotate in again, intercondylar notch. Open it up, twist it around, and then you just kind of want to let it sit there for a second. You don't want to just try to shove it in. And honestly, I don't even need to do any mallet on this. I'm just going to give it a tiny wiggle. And you can see I'm really happy with that. Really, all the borders look good. Again, don't forget, don't get too excited. You're almost done. Remember to fold it, slowly rotate it out. Mind holding the cannula for a second? Thank you. Great. And it looks pretty good. I'm happy with that. So we're going to do one more quick shaving. And then before we go to the dry, I want to show a little retraction technique. Again, we were really lucky in this specimen that we've got really good fluid extravasation, and we've done a good job with the fat pad. Can I have a spinal needle? So this is going to be really helpful. You're going to see when you start going dry, if you're not used to going dry in the scope, it can get really, you can lose a little bit of your visualization when you start to do the MACI, and obviously that part's really important. So here you're going to make sure you go past that area you took out the fat pad. We're going to pass a PDS suture. I'll take a grasper, please. Great, so we're just going to load a PDS. Again, you want an absorbable suture because if for some reason a fragment of it's left in the knee, it'll dissolve. You don't have to worry about any damage to the condyles. All right. Perfect. And again, we can just, and so you can see, if you don't mind clamping that. And you can see as you pull back, you see you have really nice retraction tissue, and that'll be really helpful in 1 second as you see now. Okay, so now we're going to go dry. This is the fun part of the case. And it's also helpful if you squeeze the back of the knee to take any fluid out. And just give it a second to kind of take any other loose pieces. Good. Good. And you can see we've got a pretty good view. And we'll just relax on the traction. So you can see without the retraction, you're probably okay. But all of a sudden that fat pad starts creeping in, boom, you can pull it back. Okay? And then as your scope sometimes might get wet, you can do a trick like this where you just touch the soft tissue. You see how it cleans off? And so now you can see here, we'll put a shaver in back and forth, but you have really nice smooth entry. There's no dam to worry about. And now we're going to do a really nice technique I learned from Dr. Kuhn, where you can put the entire sponge in the knee and really dry off the defect. All right, so we've done the sponge technique, which you saw, which did a really good job of cleaning the majority of the defect. If you want to do any sort of more pinpoint cleaning, we can use these applicators that come in the set, which are really nice. So one side is for adjustment of the MACI once it's in there, and the other side is for drying and for gentle manipulation around that area. So you can see that just want those corners cleaned. Flexion extension, again, having an excellent assistance helpful here. And you can see you can really access that condyle well. Perfect. Okay, so we're happy with the dryness of this. And now we're going to go do the cutting portion. Okay, so we've arthroscopically prepared the defect. We're ready to go. We're ready for implantation. Now what we're going to do is prepare the MACI implant. So you can see here that it's floating in the medium. It's been passed off the table. And then we're going to grab the top two corners. And we're going to lay it on the single-use cutting guide. And again, just touching the corners is good. You don't want to do any damage to the actual cells. So bottom left-hand corner, as we know from MACI before, it keeps the cell side up. And again, you never know when you're going to need to do another graft. So I always try to keep it on one side or the other of this graft. So this is the template for the one we did. And then we're going to mallet it down. And one trick, again, you can see before we hammer it down, there's a depth stop here, which is really nice. But you don't want to also hit it too hard, because if you go past the depth stop, you can actually plunge the whole MACI implant. Medium pressure, similar to taking the cartilage off, there's a tactile feedback. You want to hold the small portion of it. You want to gently start malleting down. And you can feel that side go down, and then you're going to switch sides. And you will hear a pitch tone. I do tend to lean over a little bit as I'm doing it and check to make sure that we're all the way down. And you can go back and forth. And one really nice trick that I've seen other surgeons do is where they take the graft off. You know you've cut it all the way through. You can see nothing left, and that way it doesn't get tangled. And we're going to lay it back into the medium in case you need to use it for something else. Now you remove the cutting block. Again, cell side up. And now you've got your graft ready for preparation onto the V-shuttle. Again, you can see the antennas come out. So you want to make sure that you have graft equally on both sides. So one technique, again, you want to make it as easy for you as possible, is you use a single tooth pickup. You're going to angle it down. Okay, see the V? So you want to angle it down as you do it. And you're going to slowly pull. And then you're going to rotate your hand up. You can see here that we're not perfectly symmetrical on both sides. And we're just going to adjust it a tiny bit. So you can see here that it's suctioned on there on both sides well. Cell sides up, shiny sides down. You'll see the shiny side when you place it onto the defect. You've prepared the defect, then you went back and you prepared the MACI implant on the V-shuttle, and now we're going to go back and implant the defect for the final part of the case. So I usually leave this sponge in, keep it dry. If you need to do a couple flexion extension of the knee to kind of make sure that gets there. And then you've left the tail out, so it's pretty easy to pull it out. Your camera's clean, which is nice. So now what we're going to do is do a small amount of Tissio on, and because we're at a little bit of an angle, you just got to be a little careful. What's really nice about this is the handles are in the orientation of the way you want to place it. So you see that? Now we're going to slowly go into the cannula, making sure we've got a good angle. Great. Yep, perfect. And then give me a little bit more extension. And then we're going to fire. And just give it 1 second to see how it's starting to stick. Perfect. And now you saw initially this is the drying side, so now we can use the manipulation side. And just slow movements. There's the ability to do this minimally invasively and to do it really quite easily in a wet as well as dry environment. But what amazed me the most is and what I think that most surgeons will be surprised by is the V-shuttle. The ability to pass the MACI graft, which is a delicate piece of tissue, into the patient's knee. Good. Excellent. So now it's seated well. And again, like I said, it's okay to have a little bit of a border. You'd rather have that than have the graft riding up. Okay, so now we're going to do Tacile on the top of the graft. Okay, so again, you're going to slowly put it in there. Maybe we'll do a little bit. Again, start off to the top and let it guide down. A little bit more. There you go. And you can see how it's going on to the, there you go. And then we're going to go over here and do some medially. It's a little bit extra. Good, you can almost just sort of drag it down too, and then we'll clean that up in a second. So this applicator is really nice to make sure you don't catch it. And so you can just rotate it off and just let it sit there in the fat pad. It's not going to do any damage. Do you mind giving a little bit of just a little bit of extension? Okay, and then you can just rotate it. And now try to flex back up. There you go. And now you're going to sit and wait for 3 minutes, and then you'll range the knee. So I usually do a few cycles just to feel really confident. And I'm going to almost maximum flexion and extension. And you can see here there's no movement of the MACI implant. That's exactly what I want it to look like. And then what we're going to do is just remove the cannulas, be done with the case, start range of motion promptly, and thanks.
Indication: MACI, autologous cultured chondrocytes on porcine collagen membrane, is an autologous cellularized scaffold product indicated for the repair of single or multiple symptomatic, full-thickness cartilage defects of the knee, with or without bone involvement in adults. Limitations of use: effectiveness of MACI in joints other than the knee has not been established. Safety and effectiveness of MACI in patients over the age of 55 years have not been established. Important safety information: MACI is contraindicated in patients with a known history of hypersensitivity to gentamicin, other aminoglycosides, products of porcine or bovine origin, in patients with severe osteoarthritis of the knee, inflammatory arthritis, inflammatory joint disease, or uncorrected congenital blood coagulation disorders, in patients who have undergone prior knee surgery in the past 6 months, excluding surgery to procure a biopsy or a concomitant procedure to prepare the knee for a MACI implant, or in patients unable to cooperate with a physician-prescribed post-surgical rehabilitation program. Malignancy: the risk of MACI in patients with malignancy in the area of cartilage biopsy or implant is unknown. Expansion of malignant or dysplastic cells present in biopsy tissue during manufacture and subsequent implantation may be possible. Transmissible infectious diseases: because patients undergoing procedures associated with MACI are not routinely tested for transmissible infectious diseases, cartilage biopsy and MACI implant may carry risk of transmitting infectious diseases. Presurgical comorbidities: local inflammation or active infection in the bone, joint, and surrounding soft tissue, meniscal pathology, cruciate ligament instability and misalignment should be assessed and treated prior to or concurrent with MACI implantation. Product sterility: final sterility test results are not available at the time of shipping. The most frequently occurring adverse reactions reported for MACI, greater than or equal to 5%, were arthralgia, tendinitis, back pain, joint swelling, and joint effusion. Serious adverse reactions reported for MACI were arthralgia, cartilage injury, meniscus injury, treatment failure, and osteoarthritis. Use of MACI in pediatric patients younger than 18 years of age or in patients over 65 years of age has not been established. The MACI implant is not recommended during pregnancy. For implantations post-pregnancy, the safety of breastfeeding to an infant has not been determined. To report negative side effects, contact Vericel Corporation at 1-800-453-6948 or FDA at 1-800-FDA-1088, 1-800-332-1088, or www.fda.gov/medwatch. For more information or to view full prescribing information, please go to maci.com.